And you're on twice.
This meeting is being recorded.
Sorry, I'm just testing the recording. Go ahead, Pat.
Yeah, you're on twice.
I know.
Okay. We like you to.
She's
You could be on
important.
more than once.
Okay, we're ready.
Okay. We have some business to take care of today. And that is our nominating of our new board. We have to present our board to you and get your okay for that. So I'll call out the names of the people, and if you'll use your computer hand, raise it, and keep it up if it fades off, so that everybody can see who the board is. Kurt is not here. He is our president, and we're very, very happy that he does such a great job. I am the vice president. Edna Murphy is our secretary, so use your computer nod if you can to show it. Mine's already faded out. Isn't that interesting? Treasurer is Tom Schinderling. And Ways and Means is Gretchen. And
Use your computer.
what?
I was telling Gretchen to use her computer.
It went off. It's going off too fast. Data, keeping the records of names and addresses on a spreadsheet, as well as doing the keeping the website up to date, and Facebook is Jocelyn. Pep Talk is Karen, who is not here. She is sick. Leader of the callers is Yvonne, who is, there's, you are back.
There you go.
Thank you.
Thank you.
And at large, we have Nancy Kimball, who does the birthday cards and condolences, Finn Martin, Mary Lee Coe, and Jackie Tosolini, who keeps us up to date on the medical end of things and the speakers. I would like, if possible, if somebody would make a motion to accept this group as your board for this next year.
So moved. Bob Valentine, I make the motion.
Thank you. And anybody second?
I'll second.
Okay. And all of the board can make sure their hands are down. And so now, all those in favor of the board as presented, please raise your hand. I think we're all on one screen, most of us, so you could do a manual. And those opposed? Sorry, Tom. You can't get out of it.
I can only try.
Yes, yes.
All you can do is say no.
We did. We said no.
So that's your board. And your board is a wonderful team of people that help put everything together. We haven't been as active during this COVID time because we can't get together, but we keep working on that. And if all goes well with the numbers, we plan to be back at China Buffet next month. So keep your eyes on the PEP Talk for verification of that when the next issue comes out. I just have a little bit, we lost one of our board members this past month, Bibi Bonell, that most of you would know. she's just like wonderful, wonderful woman on the board, well respected. She graduated from the rehab program in October of 2011, and shortly after that joined the board. And her main focus during her time on the board was facilitating the multitude of PEP field trips, scouting for them out, the sites out, to see if they were comfortable for seniors with COPD, preparing goodie bags for long distance bus rides, taking the reservations, collecting the money, and on trip day, doing all those last minute details, including name badges. Prior to pulmonary rehab, she and her husband Larry owned a restaurant in Manhattan Village called Coffee Cart. The cart is with a K. She loved it and it was very important to her. Interestingly enough, that even after she retired, the hostess within her was still there. And so at our board meetings, she just took over and distributed coffee and donuts and kept alert to when anybody needed a refill or a second donut. Just was part of her, it was in her blood. She is married to Larry over 50 years. And one of their passions was the classic cars. And he built her one. I just learned recently, I knew she had this 57 Ford convertible, but I hadn't realized that he had built it for her. And with that car, she won many trophies at the classic car competitions. Another interest of theirs was Cancun. And they would go to their timeshare every year in the spring, often in March. And over the years had developed a large family of fellow vacationers. She really looked forward to this trip and enjoyed it quite a bit. If anybody is interested in attending, there's going to be a celebration of life on March 5th at 12:30 at the New Life Community Church in Hawthorne. If you are interested, you can contact me. I have put my phone number and email address in the contact, the chat box at the bottom of the screen. It is also will be a virtual celebration. So if you feel you can't make it, you can still connect. We are all very sad to lose her. She will be well missed. Our speaker is he?
He's here.
He's here, yes. And Jackie, do you want to introduce him?
It's my honor to introduce him. Are we ready?
Yes.
Okay. Henry, are you ready?
Hi,
Hi.
can you hear me okay?
Yeah, I can hear you. Okay, today we are honored to have Dr. Henry Kaing. He is from Palliative Care physician at Torrance Memorial Medical Center. He spoke to our IPF group several months ago, and he's going to talk to us about palliative care and how it can help us with our chronic diseases. So welcome, Dr. Kaing. Thank you for agreeing to talk to us.
Yeah, thanks for making the time for me. I feel like I've seen some of you guys before the last time I talked, but I'm glad there's new faces. I'm happy to just introduce palliative care and what that is. I don't know if anyone here has heard of palliative care and what that might entail. happy to hear any kind of thoughts.
Everyone is muted, so if you're going to share, you need to unmute.
I was just going to say, I only have a small little box in the middle of the screen when he speaks. Is anyone else seeing that?
No, I have everything.
Yes,
Huh,
little
It's
box.
because he's speaking through, is it a cell phone, Henry, that you're using, or an external microphone maybe? So he's not
Yeah,
speaking through his video. He's speaking through a call-in.
Okay,
okay.
Yeah, sorry about that. The desktop I'm using isn't very good with the audio, so I'm using this camera on my desktop for video.
'Cause
okay.
I'm
And then
getting like,
calling in.
it's not even you that I'm seeing. Oh, there we go.
Is that
Now I
better?
got you.
Yes, yes.
Oh, that works.
Okay, I got you now. Thank you.
Hi.
So palliative care is good for anybody with a chronic disease. Is that right?
That's right. Yeah. We sometimes have it referred to as supportive care, but essentially palliative care is, a pretty new specialty that's focuses on support and palliation, so relief of suffering, and that can be, relief from suffering in any kind of realm of someone's life. It can be physical suffering or pain or symptoms, shortness of breath. It can be, yeah, perfect. It can be, support from a psychosocial standpoint, helping patients talk to their loved ones, family and friends about the chronic or life-limiting illness that they have, how to present that information, how to process that information, spiritual support. Oftentimes, a palliative care team has a chaplain who's able to kind of explore spiritual distress and their journey through faith and spirituality. So it's pretty holistic, person-centered kind of avenue of care that's I think much needed in this day and age of really specialized care. I think a lot of times we've forgotten to kind of look at the global picture of someone and to really sit down with people and just kind of learn about people as a person, rather than people as a set of diseases or illnesses. I know this is primarily a kind of a forum for COPD, emphysema, and things like that. So I'm sure a lot of you probably have experience with exacerbations of COPD, is my guess.
Yes.
Yeah.
I'm Pat Cottrell, and
Hi,
my
Pat.
husband went with palliative care about 4 months before his passing. And it was a very beneficial for us. One of the things that I noticed with it is that our doctors, our primary care and pulmonologists, still were taking care of him, with the palliative care doctor making suggestions to us and making suggestions to the doctors. It was very relaxing for me to be aware of what the future was going to be like, and make it easier for me to assist Art in this journey. So I really strongly suggest that any of us could benefit.
Thank you for that, Pat.
I had a positive experience with your group. It's only 3 days, but it's so helpful because we didn't really know where we were going. And
Mhm.
And the lady that helped us helped reassure us at what was happening, and it was a very positive experience. Not positive losing my wife, but certainly the help that we had going that direction.
Yeah. I wanted to explore a little bit on, I'm sure a lot of you, if not all, have also heard of hospice as a term that's kind of thrown around, and that might be in conjunction with palliative care. There are differences between palliative care and hospice. Palliative care can be initiated at the beginning of an initial diagnosis of a chronic illness. Oftentimes we see patients with cancer, but it can also be organ diseases, organ failures like heart failure, lung failure, like COPD, interstitial lung disease, liver failure, renal failure, anything that can be life limiting. Palliative care is able to help patients and families process that illness and how it affects their lives. What kind of changes in their lives they might be expecting in the future, trajectory of care, things like that. Hospice is more, I guess, reserved for end of life care. There's I guess, formal criteria for needing to be at 6 months or less to be eligible, but of course that's very nuanced in itself. I guess the big point is palliative care can be a longer term method for helping people, whereas hospice is a little more kind of reserved for near the end of life. Pat mentioned something very important. Palliative care can be provided alongside treatment and curative modalities. We don't replace any one physician. We work alongside with the rest of the team, while hospice is more, because it's end of life care, there's usually one physician who's kind of taken over the person's care and kind of help support patients and families at that last moment of life. Hopefully that helps.
Now, how does one get referred to a palliative care team?
Yeah, so there's different settings that palliative care can be provided. Oftentimes it's in the outpatient setting. I myself work in the hospital, so it's not the greatest place to initiate these conversations, of course. People are patients and families in the hospital. It's a very drastic change from their normal lives, their home environment. So I guess in the hospital we get referred by the main hospital doctor. In the outpatient setting, in people's home environments, we ask them to either reach out to their primary care physician or, in this case, your pulmonologist, to see if they would be open to referring you to palliative care. There's a lot of I think education that needs to be done, even from the provider standpoint, even from the doctor standpoint. Since palliative care itself is a pretty new field, we've only been, I guess, formally required to have specialized training in this since around 2008 or 9 or so. So it's pretty young. Some doctors aren't aware of the full spectrum of what palliative care can provide yet. So, oftentimes I advise patients and families to request our assistance for anything that you may need additional support with, whether it be just talking to someone about psychosocial or spiritual issues, whether it be additional help with pain and symptom management, or just someone to talk to about, what to think of for next steps, planning for the future, things like filling out advanced directive forms or naming a healthcare agent, someone who can really act on your behalf in the future, how aggressive you want your medical care to be. Those are all things that I think, it comes across, I think, everyone's minds when they have a pretty severe diagnosis. But oftentimes it isn't brought up in conversations in doctors' clinics. I guess I would say we're the team that loves to talk about it. So anything that that's been kind of eating away at your thoughts, we're here to listen and explore.
I took the direct route. I connected with Jackie as to who to call. And so I called the palliative care. It was with a little company. And the doctor, himself came out to the house on Christmas Eve, no less, to visit us. And along the way, the nurse practitioner recommended something that Betsy had clued me in on, that morphine could be given to COPDers. And being a nurse, I kind of said, no, you can't do that because morphine slows down the breathing. But in minute dilutions, in liquid form, it really, really worked well for Art in relaxing him and getting that panic situation of difficult breathing under control. Very, very beneficial. And they was, just 2 or 3 times a day. It was just very, very helpful for him relaxing. And they also had recommended physical therapy and a home visit with a nurse. So, and the primary doctor agreed with these things. So it was very beneficial.
Thank you, Pat. Yeah, for us, it's maximizing a person's quality of life, however they want that to look like. There's, of course, each person is different. They're going to want specific things or not want specific things in their lives. And our goal is to explore that. Thank you, Pat, for bringing up the topic of morphine and opiates for shortness of breath, which I'm sure a lot of you guys have experienced, either yourself or through your loved one. I agree. Usually in small amounts, morphine or any other type of opioid medication can calm down kind of the pain receptors in the lining of the lungs, and it really helps to decrease the anxiety associated with shortness of breath and feeling like you can't get a good breath. Sometimes it doesn't help, but I think if that is something that people experience and is pretty distressing in their lives, sometimes small amounts, a couple times, 2, 3, sometimes 4 times a day, can be really beneficial in just relieving the anxiety and distress associated with shortness of breath. We're able to help out with not only the shortness of breath, but pain, trouble sleeping, nausea, anything that makes people feel kind of crummy, we're able to address and help out with.
On the home care portion that you go out to does your team go out and see these patients at home? Is it, physical therapy, social worker? Who all is involved?
So there are, I guess, different, to expand on the settings for palliative care, there are a couple outpatient focused settings. One is the traditional, you go to the clinic, you see the palliative care physician and receive kind of recommendations from them. The one in the home setting is often called home-based palliative care. So there is a provider, either a physician or a nurse practitioner or a physician assistant who can come out and see people in the homes. That's usually anywhere from once every 2 weeks to once every 4 weeks. It can be longer or shorter depending on needs. But they're able to go to the home if it's too difficult for that person to leave and go to appointments and things like that. As a team, it's not just the provider, it's also a social worker who helps with psychosocial issues and coordinating care. It's a chaplain. Sometimes we do have physical and occupational therapists who are not directly part of the team, but are kind of on an adjunctive side. What else? There are nurses, nurse aides who can come out sometimes and help out with, general care, and we assist kind of in conjunction with home health oftentimes, if it's a home-based setting. I would say the core of any palliative team is a provider, a social worker, and a chaplain.
Wonderful. Wonderful.
Yeah.
I
Question?
would like to ask if this Right to Die program, how would you go about finding out about that or wanting to use it?
Yeah, their right to die sometimes is called medical aid in dying. The term physician assisted suicide has been kind of thrown up, but I think that's less politically correct at this time. It's rapidly changing. I don't know if the most recent changes have happened, but I do know in the past, if a person does want to pursue medical aid in dying, the patient has to reach out to their doctor, whoever they feel most comfortable with, either in this case, the pulmonologist or primary care doctor, and let them know verbally that that person is interested in medical aid in dying and what that entails. You have to have 2 requests verbally over 2 separate visits. I think it's 2 weeks apart. I don't know if that's the case now. There's laws changing, especially I think Oregon is the most kind of proactive, kind of the furthest along in kind of expanding the criteria for this. There's 2 verbal requests for it, and then 1 written request that has to be kind of provided to the doctor. After that, usually each healthcare institution has their own policy on how to ensure that these requests are valid and consistent and not made under any sort of coercion from, outside influences. So sometimes you have to have pretty in-depth interviews with a mental health provider, a social worker, everything to make sure that not only are you in your right mind and consistent, but that your loved ones are aware of your request and are accepting of your thoughts on this matter. Basically, once all of that is kind of deemed valid, then the provider is able to order for those medications that get picked up, and the person is able to use them whenever they feel most appropriate for them in their kind of life setting. I don't know if you guys are interested in some kind of rough data that I remember from how many people actually end up completing this medical aid in dying. I don't know if anyone's interested or not.
Sure, why not? Sure.
Please.
Yeah, sure. I don't have specific percentages. I have to pull up the information, but I do know, I think a lot of people think about this. They don't want to lose their independence. They don't want to lose their agency as their health declines. And they want to, I think this medical aid in dying is their way of maintaining some semblance of their independence. They choose how they want their care to be provided. So kind of in that setting, I think a lot of people wonder about this and ask about this. I want to say, I think a third actually go as far as to receive the actual medication. And then of that 30% or something, a small number actually go through with taking those medications. So I think that's just to say that this is a way to just keep that independence that people so value in their normal lives. And because they've lost some of this due to their serious illness, it's a way of preserving that as much as possible, if that makes sense.
Yeah. So does your facility recognize this and will honor these people's wishes?
That's a great question. At least from the hospital side, I think any hospital in general it's very, very, very rare to do that. I think in general for Torrance Memorial, I'm sure there is a policy. To be honest, I'm pretty new to this healthcare system, so I don't know the full details, but I'm sure every large healthcare system has policies in place for people who express these. I know Little Company is under Providence, and they're a pretty widespread system, so they definitely have one. I trained at UCLA, which has one. They have a full kind of system in place to make sure that patients are taken care of when they express these requests. And I'm sure Torrance Memorial has one too.
Yeah. Do they get into the whole like the Burns depression scale and all these other things prior to make sure that this person really isn't depressed? But okay.
Yeah, you can't be under, you have to be of sound mind, essentially. You can't be under the I guess the influence of depression or any sort of mental health condition that can cloud judgment or affect judgment in any way. And oftentimes that's why a mental health professional has to evaluate to make sure that the requests are consistent across time.
Interesting.
A friend of mine used it, and it was, she told me it was just from cancer she was suffering, and the meds wouldn't even take care of it. And so that's That's why she used it.
Yeah. Thanks for sharing that.
Yeah. Wow. This is a heavy subject, but it's important.
It is. I think, I think about this too. I'm in my 30s. I'm young, I'm healthy, but at the same time, anything can happen. I think it's always good to be prepared for alternative scenarios. I think everyone's hopeful, as are we. We're not the team that's here to to encourage people to die, as is often the misconception. We're here to
Right.
help people live as best as they can live, while at the same time acknowledging that everyone's life is limited. Everyone's life will end on, at least in the physical world. And how do we prepare for that? How do we make sure that your loved ones will be able to carry on and not be burdened with making decisions that they might not be comfortable making, if you're not able to talk for yourself anymore. It's kind of planning for all of that, all of these scenarios that can come up.
Wow. Yeah, you're right. My father died suddenly and he refused to do a durable power healthcare directive because he was from the old school. If I fill it out, something's going to happen.
Mm.
And I had to make all his decisions. And it's interesting. I spent probably the next 5 years after his death wondering, did I do the right thing? And
Mhm.
it was really a burden on myself of, should I have done more or did I do the right thing? And the healthcare in me person kept saying, you did the right thing. But the daughter in me kept saying, maybe I should have gone further. But if he had filled out that form, I wouldn't have had those 2 years of stress worrying about if I had done the right thing. I know I did the right thing now, but it took me a long time to get back into the ER again or walk around areas of the hospital because I felt maybe guilty. But I think filling out these forms puts a huge burden on a family, takes that burden away from the family that you're following their wishes. So after that happened, my mother filled out hers and everything's been great since then. My husband and I both have a durable power of attorney, healthcare directive type things because I don't want to do this to my son. It's as
Right.
easy as that.
Yeah, going along that just real quick, oftentimes people, not often, but sometimes people do really worry that if they fill something out in paper, it will come true. I think that's okay to be worried about that. If anything, those documents, even if they're not actually filled out, it's a way of opening up these conversations. It's a way of letting your loved ones know that, hey, these are my wishes. I never want to be on machines. I want to live on machines, whatever it may be. I think I see this so much in the hospital, where family members say, we never talked about this. I wish we did, because it would make these future decisions so much easier. If mom or dad had just told me that they wouldn't want this, they wouldn't want to be on a breathing machine, let's say, you know, the family members much more supported in that that decision, as you mentioned, Jackie, or as you kind of alluded to.
Yeah, yeah. It was a tough time. And again, my brother lived in Hawaii and, I had all these questions to answer too.
Yeah.
And I think if it had been written down, it would have been an easier transition. So I'm a real firm believer in the healthcare directive. Yeah, thank you.
Yeah.
Thank you for letting
Yeah.
me.
Of course, yeah, and we're of course we're here to help with you know, processing through what the form entails and the nuances of that in people's specific illness settings. So yeah.
So if someone were to decide that they did want to enroll in palliative care, who do they talk to get that process started?
Yeah. Oftentimes it's through either their in this case, the pulmonologist or their primary doctor, and just letting them know that, hey, this is something I'm really interested in. And hopefully that referral can be made. I don't know if, I think someone mentioned that they had reached out to Jackie specifically.
Oh
So I don't know
yeah,
if that's an avenue for this forum specifically or not.
yeah. I can always help you guys get in touch with either team or what team or where your insurance is contracted at, because unfortunately nowadays we have to go according to where you're. I mean, I spent my whole career at Torrance Memorial, I mean, at a little company. However, my hospital now with my new insurance is Torrance Memorial. So you just have to find out where you go, where you're going, and
Yeah.
let your pulmonologist know. Yeah.
Yeah.
There's no reason to suffer if there's people like Dr. Hong here or Dr. Kaing, who's here to assist us. So in finding these resources. Okay, any other questions?
I hope all this was helpful.
Nancy, if you have a question, you can just unmute yourself and ask.
Yeah, okay. Okay, doctor, I have a question. What do you have to put into those letters to request it?
I don't think it has to be any. Oh, sorry. What request was it? The medical aid in dying or
Yeah,
for palliative? Okay, that is a good question. I don't know.
okay.
I haven't encountered. I haven't had a patient who actually went as far as to formally request all those 3 criteria. A lot of people ask me about what it is and things like that, but I guess without, don't quote me on this, but I would say it's probably something along the lines of, you know, me being of sound mind, know that I have this irreversible life-limiting condition. I request to be evaluated for kind of the medical aid in dying option. That's my
Okay.
guess.
And
But
then
I'm
it
happy
goes to,
then it would go to, you would likely submit it to your pulmonologist or primary
pulmonologist.
doctor. Yeah, I'm happy to look into that a little more to see if there's any specific kind of documentation you have to do. And I can always email Jackie if that's okay.
Yeah, and I'll send it off to her.
Okay, yeah, I'm happy
Yeah.
to do that. I actually don't know, so I'm really curious.
Any other questions out there?
I'm curious actually, is this something a lot of you guys think about? As in, is this kind of a passing thoughts, or is this something you guys are really contemplating, or what brings it up?
I think that's for you, Nancy. Or did you mute yourself?
I've had my moments with everything that I've been through.
Mhm.
And Jackie knows what I've been through.
Yeah, she's had a lot of medical issues and
But-
not just COPD, so.
But then I know that my loved ones that are here wouldn't approve of it.
Mm,
So
mm.
I've got one sitting right behind me.
It's hard. These you know, these options bring in not only your own personal thoughts, but it inadvertently involves your loved ones. If anything, it's a way of opening conversations and continuing conversations. So yeah, I'm happy to see if I can provide you with information, if anything. Thanks for
you.
sharing. I think that's all I have.
Okay,
We want to
Thank
thank you, Dr. Haing, for coming and speaking about this very, very important topic. As Jackie says, it's not a pleasant topic, but anything with death is not something that our culture likes to talk about.
Yeah.
It's very difficult for our culture. So we appreciate your coming and the information that you've shared with us.
Of course. Yeah.
Thank you.
and thank you again, and just email me that information. You have my email address. So thank you for taking time out of your busy schedule to spend it with us.
Sure. Happy to.
Okay,
We'll keep in
thank you.
touch.
Thank you, Dr. Kaing.
Yeah.